Thank you, Dr. Lax. We will conclude the session with a case presentation by Dr. Weiyi Tan, who is one of our senior ACHD fellows. Dr. Tan did his medical school training at Duke University and then his residency and adult cardiology fellowship, and now his ACHD fellowship at UCLA. And he's going to be joining us for an additional year of fellowship as our interventional fellow next year. He loves training and loves being underpaid. So welcome, Dr. Tan.
Hi, everyone. Thank you for the wonderful introduction. I have thanks everyone in the audience for coming today. I hope you are enjoying the lectures. And I have the impossible task of following Dr. Lax. And I have the harder task of preventing you guys from eating lunch. So I will try to be quick. Okay, so we're going to give a case presentation about the unstable Fontan survivor. And I'd like to sort of just take you through the case that Adam started earlier. And we'll just go through that and see what we see. So again, as a reminder, this is Tom. He's a 53-year-old gentleman with double in the left ventricle, pulmonic stenosis, and he's had a history of BTT shunts, and he had an AP Fontan in 1984. He's had a history of multiple arrhythmias and subsequent pacemaker and a subcutaneous ICD coil. And I think Dr. Clift said earlier, it's quite difficult to define a failing Fontan, but we know what it is when we see it. I think we can say that a patient who gets a Fontan actually starts to fail as soon as the Fontan surgery is completed. And our job is trying to stave off the eventuality of the failed Fontan. And we do a lot of things for patients, or sometimes to patients, to try to prolong their life and improve their quality of life. But at the end of the day, I think we want to all focus on functionality and the clinical status. And Adam did allude to the fact that we need to talk about advanced care planning a lot. So I'd like to, again, frame this talk in our sort of Fontan protocol. It's a good structure, and we'll talk about sort of what we do for a failing Fontan in this framework. So we'll start with hemodynamic optimization and surveillance. So I'd like to move to a sort of a timeline format here. And you can see that Tom, our patient, had a Fontan in 1984, and he actually ended up with a heart and liver transplant in late 2018. So there's a 35-year period here where a lot of things can happen. But we'll focus on sort of the last 10 years of his life. And Dr. Clift had a nice slide that showed that actually a lot of our Fontan patients have a time period of relative stability, but then they fall off a cliff. So in terms of Tom's timeline, he had sort of a clinical exercise capacity decrease around 2012 when his kid was born. He just noticed that he wasn't able to keep up as much, or chasing after a 4-year-old is very difficult. So we did try to do some CPECs to objectively quantify his exercise tolerance. And you can see that his MVO2 max was quite low, even back in 2006. And what's interesting is that his MVO2, except for the bicycle study, and for some reason patients don't like to bike, the MVO2 did not change very much. And as Dr. Lin had said earlier, I think sometimes our CPEC studies might not be as predictive for when patients really need transplantation. However, you can see that his MVO2 is still quite low for a Fontan patient. So if there's something else that we can do or try to sort of figure out why his exercise tolerance was decreasing back then, we can move to cardiac caths. And we have had a lot of presentations from Dr. Albahoz and Dr. Levy about the importance of a cardiac cath. And I won't belabor the point too much, but we can see back in 2010, I think you've seen this already, that his Fontan filling pressures were 13. And we just talked about Fontan conversion and to see whether or not it's a good idea. He actually had an exercise study, and you can see here that his mean Fontan pressures climbed up to about 30. So you can imagine that this was not probably, back in 2010, thought to be a good patient for Fontan conversion. So then we tried to kick the can down the road, as we say, with medical therapy and other options to maybe bridge him to eventual transplantation. You can see in 2016, I think you've seen this Valentine before, a lot of colors, but just wanted to highlight the fact that when he went to atrial arrhythmia and when we exercised him, his Fontan pressures jumped up again. So we actually, again, he was thought not to be a good candidate for Fontan conversion. And then finally, the last cath, this is actually right sort of very soon before his listing for transplant. You can see that his Fontan pressure is at baseline, so not in an arrhythmia, not with exercise, just at baseline his Fontan pressures had climbed up to 20. And Dr. Clift, his transpulmonary gradient was only 3, so it was important to see that we have TPG of less than 3, yeah. But anyway, so at this point you can see that he's really struggling here. So we do get labs here, and you can see that BNP had climbed up significantly towards the end of his course here. And so with the cath data, we can see that he's struggling. Is there something else that sort of can explain why he's having all these clinical problems? We do a lot of serial echocardiograms, and throughout the years, he's had tons of echoes, but we saw a significant decline in his left ventricular ejection fractions around 2015. To sort of mitigate this problem, and Dr. Lurie talked about this in our stable talk, he's been on beta blockers, he was on ARBs, aldosterone inhibitors, PDE5 inhibitors, but when his ejection fractions started to decline, we said, we have this new drug, why don't we try Entresto? And so we were super excited about this. I don't know if you saw his data, but there was one patient that didn't do very well, unfortunately. This is our guy, but his EF did decline, and unfortunately, when we started the Entresto, his creatinine also worsened. So at this point, we're also struggling to deal with end organ dysfunction, and he's by definition meeting all the criteria for heart failure. So we're hitting an endpoint here. And then in terms of his arrhythmias, we're moving on to the next section of Adam's Fontan protocol checklist. For a long time, he was actually quite stable, but did suffer atrial fib flutter back in the 90s. He had his right atrial thrombus. I think you saw that echo. That was from his TEE in the early 2000s. And then because of continuous sinus node dysfunction and AV block, he ended up having a pacing system placed and an ICD for primary prevention. In 2013, we were stabilized with antiarrhythmics and beta blockers. But again, over the course of the years, and also Coumadin for his thrombus, he was still having more atrial arrhythmias closer to the end of his, like around 2018, and that's probably contributing to why his ejection fraction went down and contributing to his worsening symptoms. So we even tried an ablation, which helped for a little bit, but you can see the end of the time, around 2018 was when he was having more problems. In terms of liver disease, this is the one thing that wasn't too bad for Tom. We'll again focus at the last 10 years or so. And he had serial screening labs and imaging studies, and throughout the years, they weren't horrible. Again, we always see the coarsened ecotexture and hepatic fibrosis, but he didn't really have too much in the way of cirrhosis. He did have a 50-year-old EGD and colonoscopy that everyone should have, and he had a liver biopsy and the 2 caths. And someone was asking earlier in the audience about, what is the appropriate interval for liver biopsies? And in our patient, in Tom, the first liver biopsy was actually quite reassuring with very little fibrosis. But then the second liver biopsy that was done in 2018, so almost less than 3 years interval change, there was much more fibrosis and some bridging fibrosis, and that's why he was actually listed for both the heart and liver. And you can see that his platelet count, while never great, did start to creep down. And we're talking about the VAST score as well. So his platelet count is a marker for synthetic function, and liver function was decreasing at that point. So to highlight everything, just want to say that functionality, clinical status is quite important. And I think hospital admissions is also a good marker for how stable your patients are. And for many years, he was never admitted to the hospital. He always came to our clinic. We saw him a lot. But you can see that he had 4 admissions for procedures, for kidney injury, for heart failure, and eventual listing, all in the last 10 years. And so when you start to see patients not only in clinic, but starting to see them come into the hospital, and we see this a lot in our Fontan, some are more regular hospital visitors, we have to start really thinking about advanced care planning at that point. So again, in summary, you want to ask, when is it appropriate to transplant a Fontan? Because when you go from failing, you really have to make the decision that they're now failed. And if someone has pump problems, has a rhythm issue, and has liver disease, you have to sort of go with a fine line. If they just have one problem or one issue that we can try to manage, maybe they're too healthy and we can try to get them through their issue safely with either cath procedures, EP procedures, medications. However, if they have all three things going on, where they have liver dysfunction, end organ damage, their EF is poor, they may be too sick for a heart-liver transplant. These transplant surgeries are very complex. You'll hear about in the next section, and are very high risk. So again, some patients are just too sick for such a high-risk procedure. And so I just like to think of it as a simple person, the Venn diagram, when you have two problems and maybe a third that's just creeping up on you, where they have two issues that are going on, maybe they're just the right patient to think about listing for heart transplant. They're too sick for a conversion, but maybe just right for transplant. And that's really about it.